Dear student, I am Dr. Prakash Mungli, professor in Biochemistry. I did my MD from Kasturba Medical College, Manipal University. In this video, I will be explaining you all about riboflavin, that is vitamin B2, and also niacin, which is vitamin B3. Now let's get into riboflavin. Riboflavin, it is initially isolated from milk. That's why originally this particular vitamin, it was called as lactoflavin. Let me write it down. Lactoflavin. Lactoflavin is the original term for riboflavin. Otherwise, this riboflavin, it is a isoalexazen ring with ribitol side chain. So here is the isoalexazen ring here, and the ribitol side chain is attached to isoalexazen ring, and this ribitol, it is a ribose sugar molecule. As you can count the number of carbons, 1, 2, 3, 4, 5. There are 5 carbons in the side chain sugar, so it is a ribose sugar molecule. Now, as such, riboflavin, it is highly sensitive to light. That's why whenever a riboflavin vitamin is stored, so it has to be stored in a container that protect against photo degradation. Usually it is stored in a colored bottle. Though riboflavin is not significantly synthesized in our body, but considerable amount of riboflavin can be synthesized by the bacteria that is present in our intestine. Like intestinal bacterial flora are one of the sources of riboflavin, although not in significant quantities. Now, why do we need riboflavin in our body? Riboflavin, it is a component of 2 coenzymes that are necessary for our metabolic functions, especially the enzymes that are involved in metabolic reactions. What are the 2 coenzyme forms of riboflavin? One is a Flavin Mononucleotide, which is referred as FMN, Flavin Mononucleotide. And also you look at the name of vitamin, that is riboflavin. There is flavin there in the riboflavin. So, and the coenzyme, it starts as Flavin Mononucleotide. Now, the other coenzyme form of riboflavin is Flavin Adenine Dinucleotide, FAD. Now, Flavin Mononucleotide, it is formed in the intestine, whereas Flavin Adenine Dinucleotide, it is formed by the adenylation of FMN in the liver. So, make sure you remember FMN is synthesized in the intestine, whereas FAD, it is formed by adenylation of FMN in the liver. You got to be careful about it to know the location of FMN and FAD formation. So, just to repeat one more time, FMN is formed in the intestine and FAD, it is formed after adenylation. Adenylation means addition of adenine, base adenine to FMN. So, that makes Flavin Adenine Dinucleotide. Alright. So, now let's look at coenzyme functions of riboflavin. Riboflavin has 2 coenzyme functions. So, one is FMN and other is FAD. So, what are the enzymes that need FMN as the coenzyme? So, FMN is the coenzyme for L-amino acid oxidase, and also it is a component of complex 1 in the electron transport chain. So, these are the coenzyme needs for FMN. Now, coming to FAD. FAD dependent enzymes or proteins. So, because FAD can be required as a coenzyme for certain enzymes, and also it is required as the part of a protein complex. So, first let us see where FAD acts as a part of a protein complex, and that is in complex 2 of the electron transport chain. As you all, you are going to study about electron transport chain, which has got complex 1 to complex 4. So, complex 2 in the electron transport chain, that needs FAD. It is a component of complex 2 in the electron transport chain, and also FAD, it is part of microsomal monooxygenase system of enzyme. That's the second one. And the third thing is, like, FAD is a coenzyme for so many enzymes in our body, and I'm going to give you the list of all the enzymes that needs FAD as the coenzyme. What are all the names here? D-amino acid oxidase, that's one of the enzyme that needs FAD as a coenzyme. And then we have succinate dehydrogenase enzyme. This succinate dehydrogenase enzyme, it is part of our TCA cycle. TCA cycle, succinate dehydrogenase enzyme comes in. And then acyl-CoA dehydrogenase. Acyl-CoA dehydrogenase, it will come in beta oxidation of fatty acid, where you will see acyl-CoA dehydrogenase. And then we have glycerol 3-phosphate dehydrogenase enzyme. Glycerol 3-phosphate dehydrogenase, it is involved in shuttling of FADH2 from the cytoplasm into the matrix of mitochondria, something called as glycerol phosphate shuttle mechanism. That's where glycerol 3-phosphate dehydrogenase comes in. And then enzyme xanthine oxidase. Xanthine oxidase is involved in uric acid formation, or the degradation of purines into uric acid synthesis, and that's where xanthine oxidase comes, and that's a FAD dependent enzyme. And then we have three complex enzymes which we have already seen in vitamin B1, that is thiamine pyrophosphate as a coenzyme. So three complex enzymes which needs FAD as the coenzyme also is pyruvate dehydrogenase complex, and then we have alpha ketoglutarate dehydrogenase complex, and then we have alpha keto acid dehydrogenase complex. So all these enzymes, they need FAD as the coenzyme. Okay, now let me recap all of them. So FMN and FAD, what are the enzymes that need FMN as the coenzyme, what are the proteins that need FMN as the coenzyme, or what are the proteins or enzymes that needs FAD. One more time. So FMN is necessary for L-amino acid oxidase, complex 1 in the electron transport chain. FAD is necessary for complex 2 in the electron transport chain, microsomal monooxygenase elongation system of enzyme, and then FAD is the coenzyme for D-amino acid oxidase, succinate dehydrogenase, acyl-CoA dehydrogenase, glycerol 3-phosphate dehydrogenase, and then xanthine oxidase, which is involved in uric acid synthesis, and then three complex enzymes, pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, and branched chain alpha keto acid dehydrogenase complex. Now let's move on to see what are the dietary sources, absorption and transport of riboflavin. Good source of riboflavin is the milk and milk products, and high concentration of riboflavin is also seen in yeast, and considerable amount of riboflavin is present in organ meat, whole grains, eggs, vegetables, nuts. Nuts are good sources of riboflavin. Coming to absorption and transport. So riboflavin coming from food protein, it is in the form of FAD or FMN, because these are just coenzyme forms of riboflavin. That's how it comes into our body. So these need to be digested in the stomach to release riboflavin. So basically it has riboflavin part of this FAD and FMN need to be separated, and that happens in the stomach with the acidity and all that. So now riboflavin is primarily absorbed in the proximal small intestine via rapid active and saturable transport system. And riboflavin is active once it is absorbed, once the riboflavin is absorbed into the enterocyte. In the enterocyte, riboflavin is activated into FMN, and that is Flavin Mononucleotide. Basically, one nucleotide is added to riboflavin to make FMN. So FMN is made in the intestine, as we have already seen in the previous slide. Now, and this FMN is transported, riboflavin is transported in the blood stream as flavin protein complex attached to a protein, and then as it is taken into the system, so it is taken up by the tissues. However, the riboflavin is not stored insignificant quantities in the tissues, but it can be mainly stored in the liver as FAD. So, flavin adenine dinucleotide, it is stored in the liver. So, basically FMN, that is coming from the intestine, so it will be converted into FAD after adenylation process, which happens in the liver. So, make sure you remember this. So, riboflavin coming from the food which is digested and released, riboflavin part of that is released in the stomach, and then it is absorbed, and in the intestine riboflavin is converted to FMN. FMN is transported in the blood as a protein complex, flavin protein complex. It is taken up by the tissues, although not significantly stored in the tissues, but it is mainly stored in the liver as FAD. FMN is converted to FAD after adenylation process. Okay. How much is the RDA for riboflavin? It is 1 to 1.5 milligram per day. Coming to causes for riboflavin deficiency. Now, diet deficient in riboflavin it can lead to riboflavin deficiency, or exposure of milk to sunlight may degrade riboflavin levels in the milk, because milk and milk source is the good source of riboflavin, and also whenever there is increased demand for riboflavin, that's like during pregnancy, lactation, or like phototherapy. So, whenever we give phototherapy for treatment of jaundice called hyperbilirubinemia, during that time, so UV light is given, so during that phototherapy, and that can actually degrade riboflavin present in the blood. So, at that time there is need for riboflavin supplementation. And also, if there is any malabsorption disorder going on in the patient, malabsorption means it can be celiac disease, malignancies, even alcoholism, because alcohol is an anti-vitamin. So, alcoholism can also lead to riboflavin deficiency. And consumption of drugs like barbiturates also impairs interferes with the riboflavin absorption in the intestine, and it can also lead to riboflavin deficiency. So, these are the causes for riboflavin deficiency. Now, let us move on to see what are the clinical features of riboflavin deficiency. So, the name for riboflavin deficiency is called as 𝗂𝐴𝑅iboflavinosis. Make sure you remember this name. So, riboflavin deficiency, it leads to what is called as 𝗂𝐴𝑅iboflavinosis. What are all the signs and symptoms we are going to see here? So, generally isolated riboflavin deficiency is very rare. Otherwise, it is associated with other B complex vitamin deficiency. That's because it may be part of B complex vitamin deficiency due to prolonged malnutrition or any other causes that I have mentioned in the previous slide. So, what are all the deficiency manifestations here? So, generally the mucocutaneous surfaces of mouth and skin is involved. Remember this term. So, the riboflavin deficiency affects mucocutaneous surfaces. So, what are all the signs here? Cheilitis. Cheilitis, it is the fissures on lips or the cracked lips. That's one of the sign of riboflavin deficiency. And then angular cheilitis and stomatitis. Angular cheilitis means at the angles of the mouth, so there will be inflammation, redness and inflammation on the angles of the mouth. That is what is referred as angular cheilitis. And stomatitis. When you ask the patient to open the mouth and look at the mucosa of the mouth, including the tongue, so it will be reddish in nature, like inflammation, red and kind of sore, right? So, fissures and inflammation at the angles of the mouth, and entire mouth looks red. So, that is what is referred as stomatitis. And then we have glossitis. Glossitis is a sore or red tongue. And also, one of the important thing that you got to remember in riboflavin deficiency is the characteristic color of this tongue called magenta colored tongue. Remember this. So, the magenta colored tongue is a characteristic feature of riboflavin deficiency. And then patients with riboflavin deficiency will show what is called as corneal neovascularization. What is corneal neovascularization? So, if you look at the cornea, so cornea is the center part of our eye, and it is a transparent tissue. Cornea is transparent because of the way the collagen molecules are laid down there, type 1 collagen in the cornea. So it is going to allow light to pass through the cornea, fall on the lens, and it is taken the light, it will pass the light to the retina for the vision process. So what happens here in riboflavin deficiency, the new blood vessels will flow or will run from the sclera, which is a white part of the eye, all the way towards the cornea and over the cornea. So new blood vessel formation over the cornea is called as corneal neovascularization, which is the characteristic feature of riboflavin deficiency. Otherwise, remember, under normal condition, cornea is an avascular tissue. Okay. So now, and then patients with riboflavin deficiency will have seborrheic dermatitis. What is seborrheic dermatitis? So seborrheic dermatitis means it is an inflammation of the skin with excess fat over the face, especially on the angles of the nose. So over the angles, on the side of the nose, angles of the nose, so there will be a greasy skin, and also it is inflamed. So this is what is called as seborrheic dermatitis. If you touch the skin and feel it, it is like a fatty material will be coming out of the skin and reddish in nature. The skin is reddish, and that means inflammation. So seborrheic dermatitis. And patients with riboflavin deficiency may also suffer from anemia. This is because of interference of deficiency of riboflavin with iron absorption. So that leads to anemia, and fatigueness and all the signs of anemia can be seen. And patients may have red itchy eyes, night blindness. Some patients may show cataract, peripheral neuropathy, and also some of the patients with riboflavin deficiency may show esophageal and cervical dysplasia. That means changes in the esophageal and cervical tissue towards the cancerous type. So that is what is called as dysplasia, which is one of the signs that can be seen in riboflavin deficiency. And also it has been noted that riboflavin deficiency is associated with cleft lip and cleft palate deformities. Remember, so cleft lip and cleft palate deformities can also be associated with riboflavin deficiency. Okay, now let me enumerate all the clinical signs of riboflavin that we are going to see in riboflavin deficiency. So make sure you remember, the first and foremost thing is it is going to affect commonly mucocutaneous areas. So patient will show cheilitis, angular cheilitis, stomatitis, glossitis, and especially magenta colored tongue there, and corneal neovascularization, seborrheic dermatitis, anemia. Patient may show cataract, peripheral neuropathy, malignancy changes like esophageal and cervical dysplasia, and also it can be associated with cleft lip and cleft palate. So these are the signs of riboflavin deficiency. Now, how to diagnose riboflavin deficiency? Riboflavin deficiency can be diagnosed by measurement of red blood cell glutathione reductase enzyme activity. What is glutathione reductase enzyme? This glutathione reductase enzyme, it is involved in the neutralization of hydrogen peroxide into water molecule. You know, hydrogen peroxide, if it is not neutralized, it can make hydroxyl radical. So that will be done by GSH, that is glutathione, which is the 2 protons from glutathione is used and can oxidize glutathione into GSSG, and 2 protons are basically incorporated into hydrogen peroxide to convert that into 2 water molecule. And this particular function, it is catalyzed by glutathione reductase enzyme, and this glutathione reductase enzyme, it needs FAD as the coenzyme, and if you measure glutathione reductase enzyme activity, so that will indicate the amount of riboflavin that is present in our body. So the nutritional status of riboflavin, it is measured by measuring RBC, or the red blood cell glutathione reductase enzyme activity. Okay, what is the treatment for riboflavin deficiency? So riboflavin deficiency can be treated simply by replenishing riboflavin. That means to supplement, by supplementing riboflavin, so you can treat riboflavin deficiency. Since riboflavin is a non-toxic molecule, so it doesn't show any known adverse effect, but only thing is riboflavin, if it is exposed to light and oxygen, it can make free radicals or the reactive oxygen molecules, and these reactive oxygen molecules can damage our biomolecules including the lens, and it can lead to cataracts. That means exposure of riboflavin to sunlight or the UV light and oxygen, it can actually cause cataract. So you got to be careful about that. Now there are certain riboflavin antagonists, that is dichlororiboflavin and isoriboflavin. These are two riboflavin antioxidants. So that's all about riboflavin. Now let's move on to see our next vitamin, that is niacin, which is vitamin B3. Now niacin, it is also referred as Pellagra preventive factor of Goldberg. So although it's a older terminology for riboflavin, but it is good to remember niacin can also be referred as Pellagra preventive factor of Goldberg. So niacin, vitamin B3, it is also referred as nicotinic acid and nicotinamide. Now if you look at the term niacin, as you see here, so Ni for nicotinic and AC for acid, and vitamin in that In is taken for niacin formation. So niacin is nicotinic acid vitamin. That's how you can remember niacin. Why it is called as niacin? Why we are not calling vitamin B3 as nicotinic acid or nicotinamide? It is just to avoid confusion that is caused because of nicotine that is present in the tobacco. You know, nicotine is present in the tobacco. So in order to avoid the confusion from nicotine, so instead of saying nicotinic acid, vitamin B3 is simply referred as niacin. Basically it indicates nicotinic acid vitamin. Okay. So in tissues, this niacin, it is principally present as amide form of this nicotine. So the nicotinic acid. So the amide form here. So as you see in the figure, nicotinamide, niacin, nicotinic acid. You see the carboxylic group here. That's the nicotinic acid. And the amide form of that carboxylic group is nicotinamide. That's the difference between niacin and nicotinamide. Now, there are two nicotinamide forms which act as coenzymes. One is nicotinamide adenine dinucleotide, that is one form of one coenzyme form of nicotinamide, that is niacin, which is a nicotinamide, most abundant form of niacin in the tissues, as we have already seen. It is the nicotinamide. So nicotinamide can be found in two coenzyme form. One is nicotinamide adenine dinucleotide, which you refer it as NAD, and the other is phosphorylated form of NAD, which is nicotinamide adenine dinucleotide phosphate. Okay. So whether it is NAD or NADP, so both are derived from certain molecules. One is phosphoribosyl pyrophosphate is necessary for the formation of nicotinamide adenine dinucleotide. ATP is necessary, glutamine are necessary. These are the three necessary things for the formation of nicotinamide adenine dinucleotides. One more time. So we need PRPP, phosphoribosyl pyrophosphate. We need ATP and also we need glutamine. So these are the requirement for formation of nicotinamide adenine dinucleotide formation. Now, this nicotinamide is not formed directly from nicotinic acid. It will be formed by the degradation of NAD or NADPs. So it is shown here in the figure. So NADs converting into NADPs, and NADP will undergo reaction catalyzed by NADase enzyme to form nicotinamide and D-ribose. And nucleotide pyrophosphatase enzyme also converts NAD into nicotinamide mononucleotide. So, and also some amount of nicotinic acid can be synthesized by the bacteria, intestinal bacteria, and some amount of nicotinic acid can be synthesized from the tryptophan. So, this is how we are going to get nicotinic acid, and from the nicotinic acid, so we are going to get NADs, and NADs can be converted into nicotinamide. That's how we get nicotinamide, and this nicotinamide can be further converted into NAD plus, NADPs and all that. Alright. Now let's see this nicotinamide that is formed here, whether it, so we refer it as NADP and NADP plus. So I want you to remember why we call it as NAD plus or NADP plus. In order to understand that, you need to look at the sign that is present in the nitrogen that is attached to this nicotinamide adenine dinucleotide or nicotinamide adenine dinucleotide phosphate. So there is a positive sign here, N plus is there, this positive sign is there, and that's why we need to write this as NAD plus or NADP plus. So don't get confused when you see the nicotinamide written as the nicotinamide plus as the active coenzyme form. It's only because of the positive sign that is present over nitrogen atom of the nicotinamide. Alright, now let's look at the functions of niacin. Now the niacin can participate in variety of functions in our body. So one of the function that we start with here is the oxidation reduction reaction. So whether it is NADs or NADPs, both of them, they can participate as a coenzyme for majority of the oxidoreductase class of enzymes which will participate in oxidation reduction reaction. So in general, NADs are used in oxidative pathways which are largely located in the mitochondria, whereas NADPs are required largely they are required in reductive biosynthesis pathways or anabolic pathways which are largely located in the cytoplasm. Always remember this. In an oxidation reduction reaction where NADs and NADPs are participating, so usually NADs are preferred for catabolic reactions. Let me write it down. So for catabolism, NADs are preferred. NAD plus is catabolism. And usually catabolism is largely located in the mitochondria, whereas anabolic pathways, anabolism, they need NADPs, and usually anabolic pathways are located in the cytoplasm. This is in general, you got to remember, oxidation or catabolic pathways are located in the mitochondria, and synthetic pathways, anabolic pathways are located in the cytoplasm. Oxidative pathways, they need NADs as the coenzyme, and reductive biosynthesis or anabolic pathways, they need NADPs as the coenzyme. Now, that's about oxidation reduction reaction. Now, other type of reactions where NAD or NADPs are used are ADP ribosylation process. What actually happens in the ADP ribosylation? So, NAD functions as an ADP ribose donor. So basically it is going to donate ADP ribose in certain reactions. One of the best example for that is poly-ADP ribose polymerase enzyme. So what this poly-ADP ribose polymerase does? It is involved in DNA repair mechanism. DNA repair. Poly-ADP ribose polymerase enzyme, it is involved in DNA repair mechanism. So that means NADs are necessary for ADP ribosylation process, thereby DNA damage repair mechanism will go on efficiently. That's why you need to correlate if there is any deficiency of niacin, so that can actually lead to skin damage because the skin is exposed to ultraviolet light and DNA damage has to be repaired, and if that needs ADP ribosylation, and for ADP ribosylation we need NADs, that means niacin. So niacin deficiency can lead to damage to the skin because DNA repair mechanism may not be going on sufficiently. Now, there are certain in vitro experiments. It has shown nicotinamide as a down-regulatory capacity, down-regulatory effect on pro-inflammatory cytokines. What are those pro-inflammatory cytokines? Where nicotinamide has a down-regulatory effect. So, that is interleukin 1b and then interleukin 6, interleukin 8, interleukin 12 and tumor necrosis factor alpha. All these are pro-inflammatory cytokines, and having sufficient nicotinamide, that is vitamin B3, it helps in down regulating these molecules and thereby it decreases the inflammation. So, because it is going to reduce pro-inflammatory cytokines. Make sure you remember this. It is interleukin 1b, interleukin 6, interleukin 8, interleukin 12 and tumor necrosis factor alpha. Now, and also note that nicotinamide, that is vitamin vitamin B3, it is involved in induction of activation of macrophages and it inhibits expression of intracellular adhesion molecule 1 and major histocompatibility complex. And also nicotinamide, it is a potent phosphodiesterase inhibitor and also it suppresses neutrophil chemotaxis, mast cell histamine release and antigen-induced lymphocyte transformation. So, all these molecules are, events are involved in inflammatory process. So, nicotinamide has a significant presence in that inflammatory process. It is also able to scavenge oxygen radicals and inhibit nitric oxide synthase mRNA induction in activated macrophages. Again, stating the role of vitamin B3 in inflammatory process. Nicotinamide also, it increases biosynthesis of ceramides, which upon degradation produce sphingosine. So, basically nicotinamide or vitamin B3, it is helping in the biosynthesis of ceramide and which includes sphingomyelin formation. And also nicotinamide has immunomodulator and anti-inflammatory effect also. So, all these are the functions of vitamin B3. So, it is not just in oxidation reduction reactions where catabolic and anabolic reactions are involved. It is also involved in DNA repair mechanism by ADP ribosylation. It is involved in decreasing the pro-inflammatory molecules, that is interleukins, cytokines, tumor necrosis factors and all that. It is inducing the activation of the macrophages. It is involved in inflammatory process. It is scavenging the reactive oxygen species and also it is decreases the expression of intracellular adhesion molecule 1 and histocompatibility complex 2 and also it has got a immunomodulator and anti-inflammatory role here. Now, coming to dietary sources of niacin. As you see here, both plant and animal source are the good source of niacin. So, whether it is yeast, eggs, bran, peanuts, meat, poultry, fortified cereals, green leafy vegetables, they are all good source of vitamin B3 niacin. What is the RDA? Recommended dietary allowance. So, recommended dietary allowance, it for adults it is 13 to 20 milligrams so that's for so RDA for niacin, for infant it is 5 to 6 milligrams and for children it is 9 to 13 milligram and for adults it is 12 to 20 milligram. For pregnant women it can be 17 milligram, for breastfeeding women it is 20 milligram. Basically, it is in milligram, it can vary from 5 to 20 milligram. One of the important thing that you need to look for here is the corn. Corn has indigestible form of niacin called niacin. Basically, niacin which is attached to a protein molecule here and digestibility of this particular complex may be less. So, the bioavailability of this may be less. So, people who consume corn as their staple diet, so they may be at risk of niacin deficiency. And also note that a significant amount of niacin is synthesized in our body, where a tryptophan can be converted into niacin. So, how much? 60 milligram of tryptophan is converted into 1 milligram of niacin. So, that is 60 is to 1, and this is what is 60 milligram of tryptophan into 1 milligram of niacin. That is why we write it as 60 is to 1. That means the amount of tryptophan that is converted into niacin. So, which we measure it as niacin equivalents. So, 1 niacin equivalent, it could be 1 milligram of niacin is equals to 1 niacin equivalent, that means 60 milligram of tryptophan. So, this is why we measure niacin as, we can also express niacin as niacin equivalent. Okay. So, now coming to niacin deficiency. Consumption of, what are the causes for niacin deficiency? Most common cause of niacin deficiency in developing world is consumption of maize or the corn as staple diet, and this can be seen in part of China, Africa, India, where the maize protein, that is zein, which lacks an amino acid tryptophan. So, consumption of that, so that means we have less tryptophan coming from maize or the corn, and that means less niacin is made, because 60 milligram of tryptophan equals to 1 milligram of niacin. That means lack of tryptophan means lack of niacin in the body. That is why maize or the corn, consumption of maize or corn as a staple diet can put somebody at risk of niacin deficiency. So, this is the dietary cause for niacin deficiency. Now, what are the other causes for niacin deficiency? What are the causes for niacin deficiency in the developed world? So, it can be because of alcoholism. Why? Because ethanol causes decreased absorption of most of the water soluble vitamins, and that includes niacin. So, alcoholism can lead to niacin deficiency. The second is Hartnup disease. Hartnup disease, it is an autosomal recessive condition where there will be genetic defect in the intestinal absorption of tryptophan, and also there is a genetic defect in the kidney reabsorption of tryptophan. That means in Hartnup disease patients, both tryptophan is not absorbed from the intestine, and also whatever the tryptophan that is present in the blood, which is filtered by the glomerulus, so it is not reabsorbed by the renal tubular cells. So, that means it is appearing in the urine. So, on one side we are these patients are not absorbing intestine from the intestine, so not absorbing tryptophan from the intestine sufficiently, and then the other side they are not reabsorbing tryptophan from the renal tubular cells. That means allowing that tryptophan, whatever the tryptophan that is there, allowing that to go into the urine. So, there is a loss of tryptophan in the urine. So, tryptophan absorption in the intestine is decreased, and tryptophan reabsorption in the kidney is also decreased. So, overall leading to tryptophan deficiency. So, when there is a tryptophan deficiency, that will give rise to niacin deficiency, because 60 milligram of tryptophan is equivalent to 1 milligram of niacin, and that is what is the cause for niacin deficiency in Hartnup disease. Coming to carcinoid syndrome, what happens in carcinoid syndrome? In carcinoid syndrome, there will be increased diversion of tryptophan into serotonin rather than niacin formation. So, normally, 90% of the tryptophan is diverted into protein synthesis, around 9% of the tryptophan is going into niacin formation, and around 1% of tryptophan going into serotonin formation. So, here there is increased diversion of tryptophan towards serotonin rather than niacin. So, very less tryptophan is very less niacin is made from the tryptophan. That is why patients with carcinoid syndrome may also suffer from niacin deficiency signs and symptoms. Now, deficiency of micronutrients can also lead to niacin deficiency. Why? Because micronutrients like iron, riboflavin and pyridoxine, that is iron, vitamin B2 and pyridoxine is vitamin B6, all of them are necessary for the conversion of tryptophan into niacin. So, as we already know, 60 milligram of tryptophan is converted into 1 milligram of niacin. So, for this conversion, we need iron, we need vitamin B2 and we need vitamin B6. So, if there is a deficiency of these molecules, that is iron, vitamin B6 and vitamin B2, that can also put them at risk of niacin deficiency. Now, malnourished individuals may have niacin deficiency because good nutritious diet is not taken in. And one of the other important point that we need to remember here is anti-tubercular drug like 𝐒𝐮𝐬𝐴Z may also put someone at risk of niacin deficiency, because 𝐒𝐮𝐬𝐴Z, it causes pyridoxine deficiency, as primarily 𝐒𝐮𝐬𝐴Z causes decrease in vitamin B6, and when there is decrease in vitamin B6, since vitamin B6 is necessary for the conversion of tryptophan into niacin, so that will decrease niacin. So, that is how the connection. It is not a direct connection with anti-tubercular drug 𝐒𝐮𝐬𝐴Z leading to niacin deficiency. It is 𝐒𝐮𝐬𝐴Z, it decreases pyridoxine, it causes pyridoxine deficiency, and thereby pyridoxine, which is necessary for the conversion of tryptophan into niacin, so that leads to niacin deficiency. So, it is an indirect effect. And also long-term administration of 5-fluorouracil after consumption of kombucha tea, prolonged diarrhea, cirrhosis of liver, HIV infection, all these can be other causes for niacin deficiency. Now, let us move on to see what are the deficiency manifestation of niacin, which is referred as pellagra. So, niacin deficiency, it leads to a disease condition called pellagra. Remember the term pellagra. So, pellagra is the disease of niacin deficiency. Now, pellagra, it is the late sign of niacin deficiency, because in the initial stages, niacin deficiency signs and symptoms, generally we miss it. It can be a kind of asymptomatic signs, so we generally do not get to notice. Now, pellagra means it is the skin that is rough. That is what is the meaning of pellagra, skin that is rough, and it is referred to thickened rough skin seen in pellagra patients. Now, based on the etiology, there are two forms of pellagra. Pellagra that is caused because of dietary insufficiency of niacin or dietary insufficiency of tryptophan, that type we call it as primary pellagra. Primary pellagra is because of dietary insufficiency of vitamin B3. Now, the secondary pellagra as the name says, it is due to other conditions that may lead to insufficient dietary intake of niacin or tryptophan, or insufficient conversion of tryptophan into niacin. So, other causes of niacin deficiency, we put them into secondary pellagra. So, primary pellagra, where direct dietary deficiency is there. Secondary pellagra is niacin deficiency that is secondary to some other disorders. So, what are the early signs of pellagra where we miss the diagnosis? It is feeling weakness, fatigue and loss of appetite, not feeling like eating food, mild digestive disturbances, some of the psychiatric or emotional distress like anxiety, irritability, depression in their mild form. So, all these things generally we miss the diagnosis there. Now, what are the later signs of pellagra? So, pellagra is characterized by 4 Ds. We will have to remember these 4 Ds, most important ones. One is diarrhea. The second D is dermatitis. Third D is dementia. And fourth D is death. And they all appear in this order. Make sure you remember that. First thing that appears is diarrhea. Second thing, after diarrhea, patient will suffer from dermatitis, basically diarrhea associated with dermatitis. And then third is dementia, that is the third sign that appears. And then if it is not treated in time, it may lead to death. So, basically there are 4 Ds here, okay? Diarrhea, dermatitis, dementia and death. Alright. So, gastrointestinal symptoms always precedes characteristic and pathognomonic dermatitis. That means as you see, pellagra begins in the stomach. Remember this. That means always it is the diarrhea that precedes dermatitis. Diarrhea appears first and then it leads to skin changes, dermatitis. So, pellagra is the only photosensitive syndrome where death is included as the cardinal clinical sign, because death is not a sign of a disorder, especially in a photosensitive syndrome. So, whereas here in the diagnosis of pellagra, as we are looking for 4 Ds, in that 4D, that is diarrhea, dermatitis, dementia, 4th D is death. So, death is also included in the cardinal feature of the disease. Now, the neurological, now let's look at the dermatitis feature. Dermatitis is seen in areas that is skin is exposed to sunlight, where it is indicative of a role of NAD plus in the DNA repair mechanism, because already I have explained you that when a person is exposed to sunlight, so the UV lights in the sunlight may damage the skin and it may lead to DNA damage. So, DNA damage repair mechanism needs ADP ribosylation process. So, poly-ADP ribosyl polymerase enzyme. So, deficiency of niacin can lead to decrease the DNA damage repair mechanism, and that leads to skin changes. Okay. In the early stage, skin it tends to be pruritic, often with painful burning sensation with features resembling that of sunburn, and later on the patient will show thickened skin, that is dry, scaly, hyperkeratotic with a parchment like appearance. So, those are some of the signs that you see in the skin changes that you see in pellagra. And also it is a darkly pigmented skin. Usually we see this, which we are going to observe this in dorsal surface of the hands, face, neck, arms and feet. Neurological manifestations include anxiety, depression, delusions, hallucination and stupor, and later it may lead to death if it is not attempted in time. So, these are 3 Ds following the 4th D. So, one more time, the first D is diarrhea. Because of the involvement of intestinal tract. Second D is dermatitis. So, dermatitis, it is scaly, pigmented skin which is roughened, usually around the sun exposed areas, and dementia, where the neurological signs seen. So, usually dementia, it begins as anxiety, depression, delusions, hallucination, stupor and all the way going into dementia, and the last one is death. So, these are the 4 Ds that you can use in the diagnosis of pellagra. Now, let us move on to laboratory studies that are done in niacin deficiency. Now, the laboratory studies here, so we need to look at the therapeutic response to niacin in a patient with typical symptoms and signs of pellagra, which establishes the diagnosis. Like when you see diarrhea, dermatitis, dementia, and you highly suspect that there is niacin deficiency in the patient. So, when we give niacin supplementation, and if the signs and symptoms improve with the niacin supplementation, so that establishes the diagnosis. And also we can measure serum niacin, tryptophan, NAD, NADP levels, which can also reflect niacin deficiency, and also it confirms diagnosis of pellagra. Now, what is the treatment here? Treatment is oral therapy with nicotinamide or niacin, usually effective in reversing the clinical manifestations of pellagra, and also nicotinamide is usually tolerated better than nicotinic acid. So, and it is preferred agent because it does not precipitate the adverse effect of niacin, usually that can be seen in the higher doses more than RDA, that is flushing, itching, burning observed after ingestion of large doses of niacin. That can be better tolerated if niacinamide or nicotinamide is used rather than nicotinic acid. That's why nicotinamide is the better tolerated vitamin B3 compared to nicotinic acid form. Now, what are the therapeutic uses of niacin other than being used in treatment of niacin deficiency? Nicotinic acid, especially in the nicotinic acid form, although it will lead to the adverse effects like flushing and itching, bloating and all that kind of signs. So, still if nicotinic acid is used, it is in the treatment of hyperlipidemias. Nicotinic acid is used in the treatment of hyperlipidemias. How much? It is 1.5 grams of nicotinic acid per day, which amounts to 100 times recommended dietary allowance. So, 100 times more than the RDA. That means obviously it will lead to certain adverse effects like skin flushing, itching, dry skin, skin rashes, and also in sometimes it may lead to hepatotoxicity. Now, what is the mechanism here? How nicotinic acid it helps in decrease in hyperlipidemias? It is because it is observed to lower total plasma cholesterol levels. Nicotinic acid decreases total plasma cholesterol levels. It is going to decrease LDL cholesterol and also it is going to decrease VLDL triacylglycerol levels. Basically, nicotinic acid it modifies lipoprotein metabolism. It lowers circulating free fatty acid levels by inhibiting hormone sensitive lipase, thereby blocking adipose tissue lipolysis. Because whenever person goes into fasting condition, so the hormone sensitive lipase enzyme is activated and it decreases, means it is going to lead to lipolysis where triglyceride flood into the blood, and that can also be prevented by nicotinic acid. So, large doses of nicotinic acid, obviously it is associated with certain side effects which I have already mentioned to you. It can be hypoglycemia, can be skin flushing, itching, dry skin, skin rashes and hepatotoxicity in rare cases. We can also use topically applied nicotinamide to a condition called as atopic dermatitis or atopic dry skin, and also nicotinamide topical application, that is in the form of ointment, can decrease facial photoaging because it is going to the skin texture changes and hyperpigmentation process can be decreased. That's why topically applied nicotinamide is used in atopic dry skin, and also it is used in decreasing the signs of facial photoaging process. So, that's all about vitamin B2 riboflavin and vitamin B3 niacin. Thank you.